Hey everyone, welcome to day 11, Transition to Telehealth, Trauma, and Are You Really a Behavior Analyst? I have 3 questions that I'm going to talk to you about today. The first is, are we truly helping the majority of ABA clinicians that are currently faced with suddenly having to transition to telehealth? The second is it possible to be a BCBA and not a behavior analyst? The third is, what do ABA and trauma-informed care have in common? So let's go with my first question, all right? And that is, are we truly helping people who are suddenly faced right now with having to transition to telehealth? So there's a lot of incredible resources that are coming out right now on a daily basis. It's really amazing, and hopefully I'm not the only one that's like, wow, I'm in a field of some pretty brilliant, incredible people right now. And what we're primarily seeing is a lot of structured guidelines for organizations and BCBAs within organizations to follow, practical tips, a lot of good stuff. And I was thinking, all right, so who's creating these resources? It really falls into really one major category, right? I mean, experts, but at the same time, there are experienced practitioners that are in well-established organizations that perhaps might not consider themselves experts, but they're putting out some of these structured guidelines and practical tips. And usually in behavior analysis, when we consider someone an expert, that means they have an extremely well-established history of either practice in a well-established organization and or a professor position. And more often than not, we define expertise with peer-reviewed publications. So it is no argument that all the experts right now that are putting out information are giving incredibly excellent advice. No argument at all. As always, though, I make it clear that I have no problems now apparently telling 3,000 plus people that I have some serious concerns. So what is concerning me today? Perhaps the advice that's getting put out there right now on telehealth and transition to telehealth, I'm concerned that it may be too expert level, right? Too high. And what's happening is that speakers are talking about topics that are incredibly valuable and unbelievably important, but a lot of these topics do require a relatively advanced degree of expertise to be able to understand, values-based decision-making, direct instruction, RFT, precision teaching, functional competency, functional mastery. These are incredibly valuable topics, but we may all right now need to take a further step back. And that's what I keep saying, is that we need to come back to the basics if you've been watching this series. And the topics I just rattled through, those aren't the basics, all right? So why might these experts be giving advice that is too expert level? Well, first of all, we value that in our field. And our history is that experts are invited to give presentations, and more often than not, they're preparing to present to other experts. They know that certain audience members might not have the same degree of understanding, and usually what an expert does is they put in more basic examples of those complex topics to be able to keep those audience members who aren't experts a little bit more engaged, right? So I have a take-home point though here. That is that practical examples for complex topics, those aren't useful for people who are still needing further support to understand the basic foundations of behavior analysis. So this brings me to my second question, which is it possible to be a BCBA and not be a behavior analyst? So hopefully everyone's with me on how rattling that question is, right? Because a BCBA is a board certified behavior analyst. Why am I asking this question? I actually first heard this question many years ago, and I thought about it and everything we're going through right now. And I thought, well, it is an entry-level credential. So then I guess we might have board certified behavior analysts that we wouldn't consider to be behavior analysts. And that's okay, because it's an entry-level credential. I'll give an example. I venture to say that if you polled BCBAs right now and you ask them what we mean when we say function, the vast majority would say that it has to do with challenging behavior or problem behavior. And they'd probably give you 4 examples, including attention, escape, tangible, and automatic. That would be what they would say function means, right? I'll give you another example. Important historical figures. I bet you that if you asked most BCBAs, they would say that ABA has absolutely nothing to do with the work of Pavlov. I would also venture to say that they would say it was all about maybe this guy named Skinner, although I did recently hear a story from a colleague that interviewed 3 BCBAs pre-COVID, and he asked them to name the top 3 most influential behavior analysts in their career. Only one could do it, which was interesting. And out of the other 2, one of them included Freud. So, okay, BCBAs, those were BCBAs. I'm going to say they're not all behavior analysts, and that's okay. It's an entry-level credential. It is. That is okay. But I do think that we need to recognize that those of you that were surprised by those 2 points that I just made about function or about Pavlov and Skinner, that you need to pause and come back and take a step, all right? And the first place to start, I'm going to say, is respondent and operant conditioning, like I was just talking about. Now, perhaps a couple of you just went, what? You didn't say anything about respondent and operant. Yeah, I did. And I'm not trying to be mean, please, guys. I'm not, okay? This is good stuff. I'm saying that if you're watching a bunch of webinars on complex topics and you don't know what I'm saying right now, then there is a concern, okay? So we're going to go through a couple examples. And why? Because if you don't know the basic foundations of behavior analysis, it's impossible to establish socially meaningful goals, okay? It's impossible to establish good operational definitions, measurement procedures, etc., right? Let alone effective supervision practices or tackling complex topics like precision teaching and values-based decision-making. It's just impossible. I need a drink, sorry. It's a little hot. And it's been long days. Usually I start by making sure you guys are all okay. I hope you are, and I hope you're still hanging in there with me right now. All right, so if you don't have a foundation, a strong foundation in the science that informs our practice, we're gonna have a problem. And if you do, here's the cool part, your clinical programming in place is likely more appropriate, the data collection is more meaningful, graphs become more meaningful. They don't become these things that you're just putting in a report, all right? Things like company-wide specified prompting procedures become more concerning. Mentalistic explanations go down. So guys, please stay with me on this. And I know some of the complex topics are more fun to listen to, but again, if you don't feel super fluent in that which defines the basics of our field, I'm arguing that you need to spend more time on that. So let's do it quickly and I'll wrap up as fast as I can here for you guys today, all right? So let's do this. Let's make every BCBA a behavior analyst, all right? And given my focus on transitioning to telehealth, this does bring me to my third question. And my third question is, what does ABA and trauma-informed care have in common? So trauma-informed care, guys, it is an approach and a framework to providing services and taking into account everything that is involved when an individual has had a traumatic experience, okay? And adjusting your assessment and clinical programming with respect to the fact that the person has experienced a traumatic experience. My goal today is not to give you a comprehensive overview of trauma-informed care. My goal is to provide an ABA-based account for the concept of trauma. And that account brings us back to those basic foundations that I was just talking about. So quick definition, trauma, a deeply distressing, I think is usually, if you Google it, right, deeply distressing or disturbing event. Usually it'll reference emotional shock following some type of a stressful event, and that these lead to long-term neuroses. If you were to speak in ABA terms, we would say long-term impact on quality of life, typically manifested by increased problem behavior and decreased appropriate behavior that helps the individual access a higher quality of life. So as an ABA professional, we got to always encounter any situation and say, all right, what is the current situation? And the current situation right now is crisis, all right? And that crisis is setting the occasion for trauma, all right? And as an ABA practitioner, then your next question has to be, all right, what is the desired state right now, okay? The desired state in the immediate moment for all of us as we're transitioning to telehealth, providing telehealth, or those of you still out there doing the direct work, thank you. Helping to decrease trauma during crisis, okay? But before we can determine how to help someone, how to decrease that trauma during crisis, we have to remind ourselves why people do say, feel, and think what they do in the first place, all right? When I say behavior, I'm including our thoughts, feelings, and emotions. And yes, that dude named Pavlov taught us something about this. Let's do it quickly. I know. CS, US, CR, no. You're all like, wait, I'm gonna memorize it. Stop. There was a dog. When presented with meat, it salivated, all right? That makes sense. It's a survival response, okay? Pavlov, ring a bell. It did not salivate, all right? That makes sense. A bell is not associated with survival, so there wasn't a physiological reaction, like in a traumatic experience, increase in heart rate, right? There's physiology that's going on here, and it didn't happen. What did he do then? He went, bell meat, bell meat, bell meat. He presented them and paired these stimuli together, presented them time and time again. And then when he removed the meat and represented the bell, what happened? The dog salivated. Please understand that and understand that that is a basic foundation to all of the work that you're doing all the time, right? I'll give you a practical example. Let's say that you absolutely love cupcakes. You're obsessed with them. You absolutely love them, all right? If that's not making you salivate, and we can go with cheeseburger, right? You love cheeseburgers. Okay, oh, vegans, sorry. An amazingly delicious salad, all right? Just picture it. Picture the image in your head. You got it. You're holding on to it. Thank you. Okay. Let's say you love running. You are running. You are running down the street and you pass one of those amazing places. Wait, hold on. Let's go with love too. Let's say you have an amazing partner and you guys have such a good time running together, and now you're running together. It's beautiful. There's running, there's love, and you run by a food establishment that is your favorite food, and the smell is there and all these stimuli are going on, right? Notice I didn't say A, B, C's or consequences or operant. We're on respondent, stimuli, stimuli, stimuli. Vicious dog attack. Vicious dog attack. Gnarling teeth, blood, horrible scenario, all right? Stop and recognize that as a practitioner, we gotta start there, right? So this is now someone who is a depressed runner, likely not running, okay? We now need to look at all of those stimulus-stimulus pairings, right? All of those things that happened. Now, cupcakes make the entire body feel horrible, all right? Just like a bell suddenly makes a dog salivate. We know how to rearrange the environment to help with that, right? Maybe we have to go all the way back to the alarm clock that went off that day before that runner went running. Change up all of those antecedent variables, right? Replacement behaviors, okay? Hopefully you don't have a vicious dog in your house. Let's get a treadmill, right? Now we start to get into the three-term contingency. Now we can look at Skinner, operant conditioning, the consequences. What are we doing to arrange the environment that the now replacement behavior for all of the responding that was going on under trauma is getting reinforced? And for the work you're doing is getting taught those replacement skills, is getting reinforced, and that any type of problem behaviors that are coming out of that we are addressing as well. But again, guys, it is both respondent and operant conditioning that explain what I just said to you, and that is trauma. And taking that approach, knowing that foundation, coming back to the basic contingencies, back to the basic behavior environment relations, all right? Those are functional relations. If I say hi to someone every day and they say hi back to me and I continue to do it, their hello is functioning as a reinforcer for me. That is functional. It's got nothing, I guess you could say it's attention maintained. Why would we do that? Me saying hi is not a problem behavior, all right? Me not saying hi to anyone right now is a problem behavior. Let's work on that, all right? And why do I have to work on that? Because a bunch of stimuli changed in my environment. Our environment has dramatically changed. So before you start jumping in to complex topics in behavior analysis, please make sure that you're incredibly fluent talking about these basic behavioral mechanisms, all right? Because the bottom line, guys, is we can change the environment and we can help that depressed runner. We can help to change anything about the setting and situation for the individuals that we're working with right now. And that is what we need to do. Antecedent manipulations, replacement behaviors, consequent manipulations, recognizing stimulus-stimulus pairings, recognizing functional relations, and making sure that we are doing everything we can to arrange a more supportive environment, all right? I am saying to you today that you need to consider this across all aspects of your clinical programming and all related caregiver interactions. Everyone's traumatized right now, all right? So I guess my last question for you today is for you to think about how can your better understanding of both respondent and operant conditioning, what some people would refer to as involuntary and voluntary behavior, how is you having a better understanding for that gonna put you in a better position to implement true evidence-based ABA based on a trauma-informed approach to care? It's a long question. You can take it, you can handle it, and I'll see ya for Transition to Telehealth 12. I might be losing my numbers, I don't know. Hang in there, take care of yourself. If we're not taking care of ourselves, we cannot help other people, and people need us right now. Thanks, everybody.